Well, welcome everyone. We're here today on the main stage to discuss a very timely and important topic in global cancer control, and that's the elimination of cervical cancer. In 2018, the WHO Director General announced a global call for action to eliminate cervical cancer, and by that they mean getting down to lower than 4 per 100,000 people per year for incidence. And in August of 2020, despite everything that was going on at the time with COVID and so many other global issues, the World Health Assembly adopted the global strategy for cervical cancer elimination. To achieve elimination, what they're calling for is that 90% of girls should be vaccinated with the HPV vaccine by the age of 15. 70% of women should be screened using a high-performance test at the age of 35 and 45. And treatment of 90% of women with a pre-cancer and 90% of women with invasive cancer managed. In Canada, when the call went out, we also started to act in this area. And CPAC, along with many other partners, developed the ECC, the Elimination of Cervical Cancer Action Plan. And despite the fact that you would think that ours would be quite different, there are many elements that all countries share in these things. Our action plan calls for 90-90-90 rather than 90-70-90. But in each of these, there are special areas which address disparities and the impact of colonialization in our own world. In HPV immunization, we do know that there are some disparities at a very high level. We know, for example, immunization rates are very good in Newfoundland, Labrador, and quite a bit poorer in Ontario. We also know that the COVID crisis has dramatically affected immunization rates, with most provinces not offering it at all in the schools for the past year and a half. The thing we did find, though, is there's no systematic knowledge, despite our excellent public health system, on the difference in uptake from groups such as Indigenous people or recent immigrants. So part of our strategy is to work with the Public Health Network and UPHN to find out how we can improve our data so that we can actually target our strategies. The second thing in our strategy is getting to HPV testing as the primary screening test to replace Pap smears. One of the exciting things about this, and 7 provinces have already started to work with us and have accepted funding to look at what they need to do to move there. But one of the exciting things is this opens up the door to self-sampling as a strategy. And some people think that self-sampling is worthwhile for women who live at a distance, but we know that many women suffer from the cultural trauma resulting from our colonial system, and that self-sampling might be a more acceptable strategy. And finally, in terms of follow-up and treatment, we do know that amongst our Indigenous peoples, we have a higher incidence in mortality, despite the fact that we are making some strides in getting screening out to them. And that's probably a lot because even when you get an abnormal Pap test, it's very difficult, especially when you're living in the remote north, to deliver that. We heard from Dr. Opera today that organizations need to lean out. And we are trying to do that at CPAC. We have First Nations, Inuit, Métis people on every funded project that we have, whether it's a provincial cancer agency or UPHN that has received the funding. And we have many proposals that have been put forward by the communities themselves. So while we move forward with this, it's very important that we look at the equity issue in Canada, but it's more important for this conference that we look at the issues around the world. And I'm going to turn it over to my colleague now, Zeev Rosberger, who's going to introduce himself, and then 3 excellent speakers who are going to give us a window into what's going on with the elimination of cervical cancer worldwide.
Thank you, Heather. I'm delighted to participate with you and with this notable panel of speakers. So I'm going to introduce all of the speakers up front, and then they will give you their talks without interruption, one after the other. Heather and I will return at the end to moderate the question and answer period in the discussion. So our first speaker will be Dr. Carlos Castro. Dr. Castro is a medical oncologist who trained at the University of British Columbia in Vancouver. He is the ex-general director of the National Cancer Institute of Colombia and past chairman of the Oncology Center of the Javeriana, I think I'm pronouncing it right, University at Bogota, and of the Oncology Center of the Fundación Santa Fe de Bogota. He is the Vice Minister of Health and the Medical Director of the Colombian League Against Cancer, I believe, at the moment. Our second speaker really doesn't need an introduction for those of you who know this area, is Dr. Princess Nothemba Simelela. She's from South Africa and is currently WHO's Assistant Director General and Special Advisor to the Director General for Strategic Priorities. She oversees the organization's work on cervical cancer elimination, gender equity, human rights, and youth. In her prior role, she served as the WHO's Assistant Director General for Family, Women, Children, and Adolescents. She has more than 30 years' experience as an obstetrician, academic, advocate, government official, and has served as special advisor to the Vice President of the Republic of South Africa on social policy, where she supported the multi-sectoral government-wide response for HIV. She also qualified as the country's first Black female gynecologist and worked for 20 years in the Department of Health. Our last speaker is also probably known to many of you and us. Dr. Gina Ogilvie is a Tier 1 Canada Research Chair in Global Control of HPV-related Diseases and Prevention and professor at UBC in the School of Population and Public Health. She's also Senior Public Health Scientist at BC Centre for Disease Control and a Senior Research Advisor at the BC Women's Hospital and Health Centre. Her research is focused on both public health and clinical aspects of reproductive health, sexually transmitted infections, HPV screening, and the HPV vaccine. And her findings have been highly influential in setting and directing health policy both in Canada and globally. So I will leave it to Dr. Castro to come up first, and then the other speakers sequentially, and you afterwards.
Okay. Okay, may I have the first slide, please?
Yes, just give me 1 second, Dr. Castro.
Okay, that's it. Thank you. Thank you, Laura. Well, I would like to start by saying thank you for the organizer for inviting me to join this excellent event. And I'm really honored to share what happened in Colombia regarding the HPV vaccination program. So next, please. This is my conflict of interest. Next, please. Okay, I would like just to start by saying or remembering that 85% of death due to cervical cancer occur in low and middle income countries, and that 75% of the world population live in low and middle income countries that only have access to 10% of the world's economic resources. And another issue is that mortality rates due to cervical cancer usually peaks between the ages of 35 and 50 years, period during which women are usually mothers whose life is priceless. You can imagine if one of these women die, they're going to leave behind them a lot of orphans. And that's what I always remember my colleagues here in Colombia, that the life of any person is priceless, but a woman, a mother, is certainly priceless. Next. The Beautiful Dream started in Colombia in August 2012, when the president and the Ministry of Health of the time were behind the campaign of vaccinating our adolescent girls from 9 to 17 years old in a 3 schedule that later on was only changed to 2 doses. And we were able to cover 97% of the adolescents in the country. That was the Beautiful Dream. Next. And these are the results of the initial couple of years, 2012, 2013. We did excellent. And suddenly you start seeing how the first dose started to decrease and the second dose even worse. And this is what really called the attention to us. What happened after that? We did very well in the first 2 years. And then
Dr. Castro, I think your audio might have cut out. Can you hear us? Dr. Castro, can you keep going? Let's see if your audio improved.
yeah, next please.
Perfect. Okay.
Okay, this is the next one. In a little town of the northern part of the country, one morning, 15-year-old of the same school of the same grade went to the ER of the local hospital with very bizarre symptoms having been treated, complaining of abdominal cramps, headache, and you name it. And someone, breathing loud, decided to blame on the vaccine. Some of these very bizarre symptoms were related to the vaccine. There is no any reason at all. And that's not the reason why all of these very good results in the beginning dropped to almost anything. Really very bad
Sorry,
vaccination
Dr.
rate.
Castro, we're having. Oh, there we go.
Yes, next.
We were having a problem. We were having a problem with your audio, but looks like it's better now.
Okay. Okay. So that was really something very unfortunate, the way the communications were dealt with. And for 1, 2, 3 years, we had very, very low coverage of HPV vaccination around the country. Arauca is a province that is in frontier with Venezuela that has the highest incidence and the highest mortality rate due to cervical cancer. And it has a lot of problems. They have a lot of still guerrillas going on. They have a lot of migrants from Venezuela. And we decided to go there to find out what was the expectations of the population, the community regarding HPV. Next, yes. And we decided using a methodology of the Johns Hopkins University that it's called the P process, in which we went there to talk to the community, to listen to them, and with the help of the community, made a communication strategy, and then produce some special materials, and then go to those places, make workshop with parents, with the girls, teachers, vaccinators. It was very important, the health providers. And with them, we started the vaccination program, and we were able to increase the vaccination from 4%, that was in the beginning when we arrived at Arauca, and we left Arauca 18 months later with 84% of vaccination. So that was a really great success. Next. And this is part of what we did. We went to Arauca, to the different towns, different populations, the community. We talked to the adolescents. We talked to mothers. And one of the best things was to convince the headmasters to open the schools back to the vaccinators, because after what happened in this town that I mentioned, they closed the doors to the vaccinators. And that was obviously a terrible situation. But we were able to convince the headmasters to open schools again, back to vaccinating schools. Next. Obviously, reaching faraway communities is a challenge. Vaccination in rural areas is a real challenge, different to vaccinating in big cities. You have to really make a lot of effort getting to the mat to convince the community of the good things about the vaccine. Try to get away of the misinformation that was polluted, was being spread in all of the media and in the radio. So it was a a big effort to try to convince the community about the safety and the efficacy of the vaccine. Next. And this is part of the thing that when you are in a city, you don't believe how difficult it is to go to vaccinate in rural areas. But it was, anyhow, it was very rewarding to see how the community responded to the effort that we were doing from the Liga, and obviously hand in hand with the Ministry of Health, because they were very, very useful. They were the ones that were providing for free the vaccine. Next. So recovering the confidence on the safety, it was done through education. And I was amazed by the fact that many parents, they didn't know anything about HPV. They didn't know a lot of cervical cancer, despite the fact that in Arauca, that was #1 cancer. So it was an educational effort that was very well received by the community. And one of the things that I learned is that if you show compromise to the community will respond. Next. Focus group with the community, as I mentioned, that was very important. Talking to the adolescents for me was a great experience, because I was able to hear them, to see these future women of Colombia. They are going to have a lot of role to play in the future of the country. The girls in my country are really something that they gave me a lot of hope in the future of Colombia. Obviously, working with the parents, that was #1. We found out that talking to the teachers, that was another thing that we found, that teachers and health providers are persons that the adolescents hear, and that was important. And tools for the vaccinators, because they told us that they felt that they were left alone after this crisis, and that the Ministry of Health didn't give them a lot of support. And obviously meeting with the media, because the media can help us or destroy this program. Next. As I mentioned, getting involved with the community is a must. And this was a little anecdote. This little girl was in one school. She was crying. Her mother was hesitant also. And I spoke to her and I said, listen, why are you so afraid? Why are you crying? And she said, because I'm afraid of the needle. And so I tell her, listen, I will let you pinch my arm. You won't vaccinate me, but you will pinch my arm and you will see that I won't cry. So she did. She pinched me. And then our deal was, if I let her pinch me, I will pinch her. So I did. I vaccinated her, and she became one of our best allies. And she was going into the media with me, telling all of her classmates that the vaccine was it was not painful, it was painless, and that she invited all of her classmates to get vaccinated. Next. The workshop with health professionals, as I mentioned before, they were very much concerned that they felt that after the crisis, none of the authorities of the Ministry of Health was supporting them, and they felt alone. So going back to talk to them and gave them the very robust evidence about the safety of the vaccine was very important. And certainly things changed with the help of all of these very important actors in this effort. Next. So, very important, vaccinate, going back to schools. That's the best strategy. That's where the adolescents are. If you remember the slide before, that in order to go to vaccinate in the countryside, you have to go in boats and in horseback riding. It's very difficult. But if you go to schools, all of the adolescents are there, and obviously it's more efficient to go back to school. And that's, we're trying to work with the Ministry of Education to give the order to open up schools again. And we certainly are looking forward that this is going to be the best strategy for the future of the HPV program. Next. We were happy to see that parents and adolescents and teachers we're very, very enthusiastic in taking the message, and that's very rewarding. Next. And those are pictures of what I told them, that HPV vaccine is a gift of life. And I was very happy to see the parents and the adolescents very happy and supporting the campaign. And I think that the community responds if you show them compromise, certainly. Next. And that's our idea. We are in the campaign that no more women will die of cervical cancer in Colombia. And that's an effort in which Ministry of Health, health providers, parents, teachers, and adolescents, we all have a role to play. And I'm convinced that if you talk to them, to the adolescents, they will help us to achieve this goal. Next. And the lesson, never give up. We created a roundtable for the elimination of cervical cancer, in which the Colombian League Against Cancer takes part, academia, scientific societies, parent associations. We are lecturing across the country to recover the confidence in the vaccine. We are reactivating the school-based HPV vaccination program. Unfortunately, the COVID showed up and schools were closed, but now they are opening them again. We have to continue a close partnership with the Ministry of Health, the UICC, the American Cancer Society, the Inter-American Development Bank, and we're working in Bogota now and in other parts of the country. We would like to replicate the Arauca project in other areas, and we're looking for financing, but we are very confident that we will help to increase the vaccination rate. And our most important lesson, talking and listening to the community and showing them the compromise. Those are the key things to change this terrible situation that we had in Colombia regarding HPV vaccination. Next. Well, that's it. Thank you so much. I think there's another one just to say thank you in English. So it was great, and hope to learn a lot of things with the other speakers.
Wonderful. Thank you so much, Dr. Castro. And Dr. Simelela is going to be joining us. I'm just going to pull up the slides. If you could just bear with me for one moment. Okay, Dr. Simelela, when you're ready, go ahead.
Thank you. Am I audible? Yes.
Yes, we can hear you. Go ahead.
Okay, thank you. Let me start by saying thank you very much to the organizers of the Canadian Global Oncology Workshop. I'm also grateful to Dr. Carlos, because what you've just shown is something extremely exciting and encouraging for those of us who've been trying hard to get countries to scale up the cervical cancer vaccination initiatives. There have been challenges, but we'll get to that as we go through this presentation. I'd like to thank also my good friend and colleague, Gina, who's a member of the Director General's expert group, and many of the other colleagues who are participating today. I send you greetings from Dr. Tedros. He is very committed to this call that he made 2 years ago for the elimination of cervical cancer. I think just from the outset, it was driven by the glaring inequities in access to commodities, to diagnostics, even to diagnostic, screening, treatment, even the treatment of advanced cervical cancer, that made him call for this elimination. The global health community and WHO in particular had never really developed such a strategy. So there was really no clear roadmap for where countries needed to go for this. So we then worked on it. Next slide, please. Really looking at what we see on this, this map of the world, where you see the highest burden is obviously in sub-Saharan Africa, countries in Southeast Asia, some countries in the Pacific, as well as other parts of the world. We were very, very concerned and, despondent about the information that came out of the research that showed that the risk of acquiring high-risk HPV increased sixfold in women living with HIV. And I think for many of the participants in this workshop, you know that sub-Saharan Africa is worst hit by HIV. And therefore, we were dealing with a double burden of disease in that part of the world. Next slide, please. I think we can pass. This is just a slide that shows what I've just mentioned. And those are countries that face a lot of challenges with access as well. Next slide, please. So in developing the strategy, we put 3 groups of modeling consortia together, and they all worked differently to define a threshold for us, because if we wanted to reach elimination, we had to work on defining what it is, where do we want countries to go, what are the targets that they need to be aiming towards, and this is what the work that they did produced for us, a threshold of less than 4 cases per 100,000, and that to move to elimination, all countries that really were carrying a big burden had to strive to achieve the 3 targets, with 1 subsumed in the second target, which is 90% of girls fully vaccinated with an HPV vaccine by age 15. The second target, 70% of women screened with a high performance test by the age of 35 and 45. And we want 90% of those with a precancerous lesion identified amongst the 70% to also receive appropriate care, and that 90% of women with advanced disease should receive appropriate care, including palliation, which is what is really weak in many of the lower income and some lower middle income countries across the world. We knew also from this work that we were aligned very much with the targets for the Sustainable Development Goals, because the modeling showed that if we achieved this, we would contribute by a 33.3% reduction in mortality from NCDs. So this was very comforting in that it came, as I said, from 3 different groups, and they all converged on the same findings. And we were elated really when nobody really questioned these stretch targets in the World Health Assembly. There was a unanimous decision to adopt the strategy, and we were then set off to try and see how best we could support countries to implement this. Next slide, please. We then just wanted to share this roadmap with you of what we did since then. Obviously, the adoption in August 2020, the launch of the strategy in November, a month after it was adopted. And then we started working across the 3 levels of the organization. I think those who don't know WHO, how we work is that the headquarters is responsible for the normative work and the guidelines and all of the work that is necessary to support the countries. The regions are also supposed to establish their own roadmaps within the defined strategy. And then the country level is where the rubber hits the ground. And not being an institution that is designed for implementation, we had to quickly also work on partnerships with those institutions and other agencies that work on the ground at country level. So in the meantime, we worked on a lot of guidance documents. We revised everything that we had on screen and treat. And just recently in July, we published screen and treat guidelines for a specific group, obviously women living with HIV, and then for the rest of population of women. We had guidelines for advanced disease. We had a lot of other work done on AI-driven technology. We developed country baseline profiles to enable countries to know the level of effort that they would require to get to the targets. Next slide, please. And now to show where we are with the HPV vaccine implementation, we know that although over 100, it's at least 110 countries of the 194 that are part of the World Health Assembly have introduced HPV vaccination programs, you can see that in the previous world maps, the burden of the disease is not where we've got huge coverage or almost 100% coverage of vaccine, HPV vaccination. Therefore, we are really on a concerted drive and an effort to get to where the disease is. Many of the countries that cannot afford the HPV vaccine are being supported through the Gavi Alliance, working with ourselves, UNICEF, and other partners to co-pay for the vaccine, but Gavi has also negotiated reduced prices, really, for low-income countries. 79 low-income countries get to pay under $5 for a single dose, whereas we know in high-income countries it costs much more. And the big issue here is that we've seen high-income countries getting more and more supplies, obviously, because they pay more. And there is a plan really to advance very robust discussions with the manufacturers to really look at equity. In the context of the COVID pandemic also, we are using this opportunity to really put HPV on the agenda of the AU, for instance, and other regional bodies where heads of state participate. Next slide. In the meantime, we've really been very excited by the fact that even during a pandemic, our inspection group were able to go and inspect a facility in China, and that a third or maybe a fourth vaccine has recently now been pre-qualified. Innovax, the vaccine is called Cervical. It's a bivalent vaccine, and we are happy that at least the market will expand. And there are some countries, Nigeria, I know, has already made advances to China through their political leadership to see if they can negotiate for themselves access to these vaccines. We know that they will probably serve the domestic market first, but it doesn't really deter us, because we also have about 3 other products in advanced phases of the trials, and we can see supply constraints getting a little bit better, maybe in the next 2 years or so. So this is very, very exciting, and I think the uptake will be tremendous, as we've seen in Colombia. There will be a good story to tell. Next slide, please. And then we have the guidelines for the prevention, for the secondary prevention pillar, and the new information there, which you may not be able to read, and I apologize for that, is that for women living with HIV, we've recommended that screening starts at an earlier age, the age of 25, and that they come back into the system for screening every 3 to 5 years. Whereas for the rest of the population, we are recommending strongly that countries move to HPV DNA testing as a primary screening method, and that you can then move from there to a triage system and or subject the women to colposcopy if you can afford it, and then treat the lesion should there be any. What is exciting about this prospect is the fact that we know that the HPV DNA tests have a strong negative predictive value, and if women are negative, they don't need to come back into the system and clog the system, at least for another, as I said, 3 to 5 years. This is really a huge advance, and we also have options for those countries that might find it difficult to introduce the HPV vaccine. Next slide. The HPV DNA testing. The idea is to move countries from, we know that cytology is very well established in high-income countries, and that this is a system that will continue probably unless, there's a strong advocacy move and or, clinicians and pathologists agree to move to molecular tests. But in the low-income countries, we know that these are tests that are not affordable and that they're quite challenging because we don't really have the human resources to do the cytology, and the results get lost, the women don't come back, and there are lots of challenges with this approach. We, as I said, are really piggybacking on the newly established platforms, and we know that in those countries that have a high HIV, we already had these laboratory platforms established, to deal with tuberculosis, to deal with HIV, and therefore, expanding these platforms in those countries shouldn't be a challenge. And that's what we believe is going to be a good selling point when we can demonstrate and show those that make the financial decisions that it's not an additional cost, it's just the cost of the tests and the reagents and whatever they require, but the platforms are there. And then to get people, trained on visual assessments, and then to move on to management of those precancerous lesions. Next slide. We also have recently published a framework for AI-based innovations. This is work that's been really, really exciting. Implementation research happening in a number of countries across sub-Saharan Africa, also in Francophone Africa, in India as well, that really has moved quite quickly. And we want to be at a stage by the middle of next year where WHO can issue guidance, because the implementation research that we are overseeing as WHO. We are not the only ones testing these modalities, and we want to have a meeting of experts in this field and agree really on what the best option and recommendation should be for lower income and low middle income countries. But we're happy that this work has advanced and that we at least could come out with a framework for how countries should approach this kind of screening methodology and how it will improve patient outcomes, as it were. This is accompanied also by thermal ablation devices, which are handheld, not requiring electricity. They're battery operated and very, very easy to carry around, moving us away from the gas tanks and all the difficulties we had with cryotherapy. So interesting, game-changing innovations that will help support countries in the implementation of the global strategy. Next slide. Yes, this is what I was just referring to, that you just need a smartphone, which many of the health providers have. And in fact, what some of the researchers are doing on the ground is just getting an oncologist who's very, oncologists are all very well trained, but to be the backup, when the nurses take the picture and send it off to be looked at, there is someone who's helping them to read what they are seeing. And if there clearly is a lesion there, we can immediately move into an ablative methodology that's appropriate for the size of the lesion. We are also working very closely with some of our partners, such as Unitaid, and very recently, during the anniversary of the launch, FIND, which is our partner in the diagnostic space, has given us great news that although they haven't worked in the cervical cancer space, they will now be moving into the diagnostics area for cervical cancer, which is something we welcomed very much. So we are working with other partners, Gavi especially, on market shaping initiatives. We hope to get to the potential for less than 50 cents per test and less than $1 for a full screen and treat. Next slide, please. We still have really big challenges. I call the last pillar of our strategy a mountain that is not impossible to climb. It's difficult, it will take some time, but there are already many things that people are thinking about. The approach we've taken for low-income countries and other places where there aren't enough human resources with the right skills is to partner with other institutions, North-South partnerships, South-South partnerships, and developing regional hubs of experts that countries can draw on, because we know we'll never get to a place where every country has the necessary human resources to do this. We're looking at ways in which we can also upskill training of nurses to make sure they can do, some of the things they've been doing away from AI to using the new technologies, away from VIA to use the new technologies. And then on the demand side, we know that there are stigma issues. It's a disease of the unaware, somebody called it, and it just struck me that that was true. Women don't come in on time, it's a taboo issue. But when we work with the HIV community, we find that we break these barriers very, very quickly. So we've got now a growing movement of women advocates who are advocating for access they are demanding these services from their governments, and we are supporting them in that regard. Next slide, please. We've also just cleaned up our knowledge base and all the publications that were on the websites of WHO. So if you go to our repository, you are able to find the latest updates on all the work that is going on in WHO. We've stuck to the color teal. As you know, that's the color for cervical cancer. And we know now that at least any document that has this color catches your eye, because it will guide you to where you need to go for cervical cancer information. Next slide. Okay, these are the country profiles I referred to earlier. I know you may not be able to see everything, but this is basically a tool for the country to use. It tells the country where they are with the HPV vaccine coverage, where they are with the screen and treat, and it also provides them, information about the entire continuum. This is what they will use to now start measuring their progress towards the targets that have been set. We're very happy that a partner has offered to make this interactive and to make it easy for countries to access on our websites. Thank you. Next slide. Yeah, we're happy also to announce that with the first anniversary, we were able to strike a collaborative center, or a partnership, so to say, with the University of Miami. It became the first collaborating center specifically for cervical cancer elimination. We've got many collaborating centers in WHO, but this one is dedicated really to help us in any way that they can, especially with North-South partnerships and making sure that, we can get more people trained in this area of work. And we are very, very proud. Those who followed the launch, the anniversary, we also had a league match played on behalf of cervical cancer in the US. We had over 110 monuments lit in teal. So we feel that a movement is growing, and we're excited to be a part of this and to see that the world is starting to really recognize the inequities and the neglect that has been part of how we've responded to cervical cancer to date. Next slide. These are just the examples of some of the documentation and publications that we have produced, and just some of the UN partnerships that are working with us. What's exciting is that of all of those UN agencies now have integrated cervical cancer into their strategies, making sure that we are not the only ones as WHO calling for this. So UNAIDS, UNITAID, UNICEF, Gavi, UNFPA, UN Women, every one of them has mentioned this. And we will also be getting more resources for countries from the Global Fund. So we were really feeling the impact of the momentum, and we hope countries will use these innovations and these opportunities. Next slide, which I think is my last. I think for me, the cream on the top of everything else was the fact that this year, WHO, or the DG, honored the Henrietta Lacks family with a posthumous award, something that really, really was quite emotional. I think it's a landmark event. It was our small way of addressing the injustice that happened with Henrietta Lacks. She would have been 100 last year, so the family has a strong relationship now with WHO. We will be working with them going forward, and there's a lot of exciting things that we will be pushing with the family more to keep the legacy of Henrietta Lacks alive. The DG has also taken a decision that every year there will be an award for an emerging scientist, specifically from developing countries, who will receive full tuition for a scholarship on any of the aspects of cervical cancer across the continuum. This, I think, was probably the proudest moment for us as a team. And I think with all the work that many of you are doing, what the Lacks family has asked is, say her name, you know. I know a lot of you use the acronym HeaLer cells. Their plea to the world is, call her name, say it out, so that the world doesn't forget her huge contribution to medical research worldwide. So that's been our journey in 2021. And with all these tools, with all the momentum, we're hoping to hit the road early next year to see how much resources we can raise for countries. And we hope that you will be our partners, as you always have been, as we get more and more people engaged and working with us on this very, very devastating disease that is preventable and potentially curable. So I ask you once again that although I'm preaching to the converted, join the movement, and let's make sure we leave a legacy that is worth leaving behind for our daughters and the next generation. Thank you very much.